I'm Sarah Ashley Ferencz. I am one of the second-year trauma fellows at Ryder Trauma Center in Miami. And today I would like to present a case of an adolescent polytrauma that we took care of in our adult trauma center. And thank you to Gary and Valeria and Pan Am for allowing me to put this together and present it for you all today. So this was a 13-year-old female. She was an unrestrained passenger in an MVC who was ejected. When she got to Ryder Trauma Center, on her primary survey, she was unable to protect her airway. She didn't have that great of a mental status, so she was intubated right away. She had decreased breath sounds on the right chest, but she did have 100% on her O2 sats. Her heart rate was 124. Her BP was 85/39. And I should say she was 13 years old. However, she was about 50 kilograms. So a pretty good sized adolescent 13-year-old. We did begin transfusion with uncross-matched blood. Her GCS on initial presentation, one of the reasons we intubated her was a 6 at that point. Her eyes were open and moving around, but she really wasn't responding or moving for us. And her FAST, when we performed it, was positive in the right upper quadrant, left upper quadrant, and pelvis, and negative in the pericardium. So I'd just like to see if there's what anybody would do at this point, if anybody has any comments for management.
Let's go to Toronto, Dr. Ali.
Yeah, well, it's early in the course. You have to be worried about a patient who is hypotensive and with a positive FAST that she may, of course, have intra-abdominal bleeding, but we don't know the source of the bleeding, and we don't know if this bleeding is from solid or hollow viscera, and whether or not it will stop spontaneously or not. So I think I will presume I will continue with management, with making sure your airway is secure. She's on a ventilator, I presume, and she's got 2 large bore IVs, Foley catheter, and orogastric tube in as well, and she's got blood has been started. Is that right? Yeah. So any external source of hemorrhage anywhere in her? I'm looking for a source of hemorrhage.
At that time, no.
I see. So in essence, this is a patient who has, until proven otherwise, bleeding in the belly, nothing externally, fractures or anything like to suggest blood loss. So it's blood in the belly, and it's blood trauma as opposed to penetrating trauma. So if it was penetrating and she was hypotensive, you're more likely to consider getting her to the OR in a short time. But with blunt trauma, I think she warrants some further assessment to see if you can stabilize her and determine more precisely what's going on in the abdomen in the way of CT scan. That's presuming you're able to stabilize her in the trauma room. And so that's what I would do for the meantime.
Thank you, Dr. Ali. Can we go to Ryder, Dr. Yee?
Yes, this was actually my patient, and I agree with everything that Dr. Ali mentioned. So we didn't hesitate. As soon as we saw the low blood pressure and the positive FAST, we were making moves to go to the operating room.
Thank you, sir. Sao Paulo, Dr. Tele, your comments, please.
Yes, I agree with the comments. In these situations, I think it's important to make an X-ray of the chest and put the patient in OR. She's in shock and FAST is positive. So in this moment, I believe this patient needs to go to OR. But I think it's important to know if there is blood or why the decreased blood sounds in the right chest. So I believe this patient need to go to OR, but I think it's important to make an X-ray, chest X-ray.
Thank you, Dr. Calais. Portland, Dr. Kasim, your comments, please.
Good morning. This is a 13-year-old female who is in shock, and I would assume that this is a compensated shock. So what you see is what the reality is. So be aware of that. And then again, she's a female. If you're going to give a blood transfusion, you also have to keep in mind whether you give her rhesus positive, rhesus negative, uncrossed mass blood. Those things come into play as well. But I agree with the concept at this moment. The patient needs to be resuscitated. More than likely, she will end up in the operating room because she's bleeding and you have to stop the bleed. Thank you.
Thank you, sir. Let's go to Iraq. Dr. Untrak, your comments, sir?
Yes, I agree with all the comments. She needs to be in the OR as quickly as possible. But in following up with what Dr. Tele said, I would, during the ultrasound exam, I would do the EFAST, look at the chest. And I think that's quicker than even the X-ray, but an X-ray is fine. But to look for a pneumothorax or hemothorax to see if she needs a chest tube, probably on the right side, and I would get that done. If it's needed, then proceed directly to the operating room. And in addition, the mental status at this point is irrelevant in the setting of hypotension. So her blood pressure needs to be corrected before you can worry about her a possible intracranial injury.
Thank you, sir. Let's go back to Ryder. Dr. Varon, your comments, sir.
Well, I agree with everybody else. The OR is ready for this patient. Basically, obviously, I agree the EFAST would be a quick way to do it. But if you want to follow ATLS guidelines, if you have a positive ultrasound and the patient is in shock, the patient deserves an immediate laparotomy. But I agree the extended fastest will be a quick way to see if there's a pneumo.
Thank you, sir. Those are the comments from all the people sharing video. Do we have any other comments before we return to our presenter? Very good. Back to you, Dr. Ferencz.
Great, thank you. So agree 100%. So we did go directly to the operating room. We performed an exploratory laparotomy. Immediately upon entering the abdomen, there was hemoperitoneum. So the abdomen was packed. Upon unpacking, we found a grade 4 liver laceration near segments 7 and 8, a grade 2 splenic laceration, and a non-expanding left retroperitoneal hematoma. At this point, she had worsening hypoxia, so we went ahead and placed bilateral chest tubes in the operating room. And then she had ongoing hypotension. So given these findings, I'd like to see what everybody thinks about the surgical options.
Go to Sao Paulo, Dr. Tele.
In this situation, the patient is in shock, hypotensive shock. So I go to make a damage control surgery, put pads around the liver. Sometimes in the spleen, maybe take a splenectomy, quickly splenectomy. Usually it's more safe than put pads around the splenic, and close temporarily the abdomen and try to make blood transfusion, compress the coagulation and the hypothermia. So in this moment, I go to stop the surgery, to packing the abdomen and wait.
Thank you, sir. Can we go to Portland, Dr. Kasim, your comments, please.
So you need to think about what is causing the hypotension. If it is continued bleeding from the spleen, if it is, splenic salvage becomes mute. You need to go ahead and remove the spleen if it continues to bleed. And then you look at the liver to see if there is continued bleeding there as well. Then you may have to repack. And then look for other areas where she could be bleeding. And in particular, if there is any injury to the pelvis. And I think you have to be just methodical to see what other area she possibly could be bleeding. A hypotensive patient in the operating room becomes a very challenging thing after you've done a laparotomy and packed everything. And if she continues to be hypotensive, it is a dilemma. But if the spleen is bleeding, definitely remove it. Don't do any splenic salvage.
Thank you, Dr. Kasim. Can we go to Iraq, Dr. Untrak, your comments, sir?
Yes, I assume that you've ruled out long bone fractures in the legs, and I gather there isn't much pouring out of the chest tubes, otherwise you would have mentioned, but is there anything coming out of the chest tubes?
Nothing significant.
Okay, all right. So then it looks like, grade 2 splenic laceration, probably it's okay, but it's probably not the source of ongoing bleeding, but a grade 4 liver laceration is pretty severe. And I don't know without being there whether it's arterial or venous. So I would try the Pringle maneuver and then trying to assess whether the liver is still bleeding. I would suspect that with no other source, the left retroperitoneum is not expanding. It's probably a stable kidney laceration that would not be the source of the bleeding. And you would have a sense in the OR if the liver is still bleeding, if the packs are getting soaked. And but if she's continued hypotensive, I would suspect that. And I would start with the Pringle maneuver. If that didn't stop it, then you have to consider, depending on how hypotensive she is, going to maybe to isolate the liver, Pringle maneuver, and then the above and below the liver, the venous access, and then including the abdominal aorta to see if that helps the shock resolve. But I suspect that is likely going to be the source in the absence of anything else.
Thank you, sir. Dr. Varon, your comments, please.
Yes, well, I'm not a surgeon, but I agree most of the comments. But the only thing that we haven't discussed is the possibility of a tamponade. I know this is blunt trauma, but a pericardial window, if you're there already, I would take a look at that, just to make sure that this is not the reason for the hypotension. If you believe that you control the bleeding and nothing is coming out of the chest tubes.
Mm-hmm. Thank you, Dr. Varon. Dr. Yee?
Just as a follow-up, we had done a fast in the resus bay, and I was very confident that there was no tamponade back then. So I did not choose to do a window at this time. And you'll hear from Sarah actually later on about what happened next. I don't want to steal her thunder, but I felt at this point that I had essentially ruled out the a tamponade based on my ultrasound that was just performed maybe 10 minutes prior to this operation.
Thank you for your comments, sir. Toronto, Dr. Ali?
Yes, I would make sure that I really have that liver well packed and that the bleeding is reasonably controlled and would allow me to have a good look around in the belly to make sure there isn't any bleeding elsewhere, anywhere else in the abdomen. If there's a renal laceration, it seems like it's stable, it's non-expanding. So it makes sure that there isn't any bleeding elsewhere. And I won't go to Pringle maneuver and so on unless the bleeding really continues in spite of packing. Then I would go to other maneuvers. But at this stage, I would like to know whether the bleeding has, and to what extent the bleeding has been controlled with packing of the liver, and whether or not you went ahead to remove the spleen if the spleen was actively bleeding. Before I go on any further, what was the state of the bleeding from the liver with the packing?
It was decently controlled, but I'll get to what we did next.
Mm-hmm. All right. If that bleeding is controlled with packing, I would leave the packing in there until and make sure we look at the patient's clotting parameters and so on, as we have collected before, to make sure there isn't any reason for continued bleeding on a hemostatic basis, and see if the liver laceration requires surgical intervention to stop the bleeding. At this stage, it doesn't appear certainly so, but it may declare itself later on.
So just as a follow-up, so we got in, there was probably a couple liters of blood. We did the initial packing simply just to mop up all of the blood and place our packs in. During this time, that's when our anesthesiologist turned to us and said, hey, the patient's getting more hypoxic.
I see.
The diaphragms were not billowing out towards me. Even though I did not suspect a tension pneumothorax, I went ahead and placed bilateral chest tubes. And there was a minimal blood and maybe a small gush of air on the right, but nothing that I would consider impressive for a tension pneumo. And then, so that was, in the first, couple minutes of the operation. And then that's where we are right now, where we haven't really had time to go back and reassess the packs in the right upper quadrant because we were dealing with the hypoxia in the chest tubes. But this is really no more than like 2 or 3 minutes into the operation at the end of this slide right here, where we're seeing the hypotension.
Dante, did the patient have a central line?
At this point, I don't know. I wasn't aware of what was going on above. I was focused on the bleeding.
The reason I'm asking this is very simple. The patient has central line. If you transduce it, you're looking for 0 or 40. If it's 0, it's continue bleeding. If it's 40, it's tamponade. It's just a quick way to figure it out.
Sure.
Without having to do a window.
Okay, very good. Any other comments before we return to our presenter? Okay, back to you, Dr. Ferencz.
Okay, so we thought everything everyone else had mentioned. So at this point, we did do a Pringle maneuver with intermittent release. And that seemed to control the bleeding. So we went ahead with hepatorrhaphy, but we noticed that clinically, she just had continued coagulopathy. We had a decent control of the bleeding from the liver. And so we were thinking, what do we do now? We would love to keep a spleen and do splenic preservation in a 13-year-old, but we went ahead and elected to remove the spleen as well as the source.
So just to clarify, what the Pringle with intermittent release was, I use my finger. I put my finger around through the foramen of Winslow. I pinch it with my hand so I can really feel that thrill of the hepatic artery. I clamp it shut and then I hold it for 5 minutes. And then every 5 minutes I release it and let it perfuse, and we see the status of the bleeding. So it definitely improved with my hands clamping it. And then after waiting 5 minutes, I sort of reperfused, and then for about 30 seconds to a minute, and then clamped it again. During this time, we're monitoring the ABGs, and we continued the cycle for about 3 or 4 rounds, and every time it seemed like the base deficit was slowly improving, and anesthesia was definitely catching up. But we did notice that there was ongoing coagulopathic bleeding at this point.
Yes, so. But while performing our splenectomy and clamping the splenic hilum, she did go into ventricular fibrillation. So I'd like to get a poll of what everybody would do at this point as well, knowing that we have pretty decent control of the bleeding from the liver with the intermittent Pringle.
Dr. Kassim, your comments, please.
Pray first. Ventricular fibrillation in the operating room is a nasty thing, as everybody knows. So you have to control that either with medication or ask for help from Dr. Warren and see what he would suggest. Sometimes, you can bleed into the substance of the spleen itself, and that will not manifest itself, and you would have lost a liter of blood or more. And that's why I suggested earlier on that if you have any doubt, I know splenectomy in a 13-year-old is fraught with danger, but post-splenectomy sepsis in situations like that is real, but sometimes you have to do that. Otherwise, your patient dies of hemorrhagic shock. So I would.
Patient is warm.
How much blood had the patient received at this point? Do you have any idea?
I don't have the exact numbers, but she was on MTP. She was on the massive transfusion.
The reason I say that because the common mechanism that we see is once you give a lot, hyperkalemia is the killer. BTAC, BFib. So I would suspect that the patient got hyperkalemic with the massive transfusion. Obviously, at this point, defibrillation and calcium administration, if you suspect this hyperkalemia, would be there while you're trying to figure out the etiology of the continued decompensation.
Were you able to control her temperature, core temperature? Was she getting warm fluids, and her core temperature was controlled reasonably well as a reason for the cardiac dysrhythmia, the ventricular fibrillation?
Well, at this time, I don't know exactly what her core temperature was. I do think it's standard practice for our anesthesiologist to run the massive transfusion through the fluid warmer. And I don't, when we review this case, I don't recall that it stuck out. It didn't jump out at me that they deviated from our standard care.
I want to make a point on hypothermia in these cases. It's rare. It's really rare because most of the patients that get MTP, they're bleeding out blood, and we're giving them blood at 42 degrees at massive amounts. So hypothermia is usually in the mass, and MTP is, it used to be when we have these infusers, but the current infusers, hypothermia is rare, is remote. Unless, you know, you see it in the lab chole that you give very little fluids, you'll see hypothermia. But in MTP, no, because we're getting really hot blood is going in as blood is coming out. It's like being on cardiopulmonary bypass.
So my reason for asking that is just sometimes in the rush, you end up with blood transfusion and not being very prepared. The patient can indeed become hypothermic. But and being aware of that, you'll prevent it. And of course, prevention is better than anything else in terms of the hypothermia. But in terms of the ventricular fibrillation, in a patient who's in the operating room, it still is preferable to try external shock to defibrillate the patient rather than, unless the patient is totally hypotensive without any circulation, then you may have to, in addition to warm fluids, get in there and do open cardiac massage to maintain some degree of stroke volume.
She was completely hypotensive. She was in VFib with no pressure.
All right. Okay. So you open her chest, I presume.
Is that a question for presenter?
A question or a comment? Well, I think it's already almost 12:30. We have a lot more to get to the case.
Right.
If it's okay, we'll proceed.
Yeah, let's let Dr. Kassim finish his comments and then get something from Dr. Tele and Dr. Ontrak, and then we'll continue.
I would not open the chest at this moment. I would resort to medical management, and you know, a fellow like Dr. Vernon will be very, very helpful to me at this moment. I would put my money on him and say, would you like to try some medical management first? It shouldn't take very long, you know, whatever he gives, it should reverse that if possible. And I would rule out things like air embolism, other embolic phenomenon, including the coronaries, and your chest tubes are in the right place, not hitting the heart. Chest tubes have not gone through the heart. That's there was a case like that at the UCLA UCSF recently that I heard about. So all those are possible. You know, this is a 13-year-old patient. It is not because of ischemia that this phenomenon is occurring. There is something else happening here that you have to be a Sherlock Holmes to be able to figure it out.
Thank you, Dr. Kassim. Can we go to Dr. Tele, please?
Okay. I think as patients continue hypotensive, there is an hemorrhage shock continues. So in this situation, you have to compensate the patient. You can cross clamping the aorta in the hiatus can maybe more effective than to control the hemorrhage through the abdomen at this moment. And if the patient is near to be a cardiac arrest, if the patients go to a cardiac arrest, I go to a anterolateral thoracotomy and external massage in this situation. But I think this patient is not control the hemorrhage acutely, so they need some another maneuvers to try to decrease the hemorrhage to continue the surgery, to continue the resuscitation of patients. I believe in these situations can be cross-clamping the aorta near the hiatus is a possibility, and then wait, and maybe if patient continues to make a cardiac arrest, go to the thoracotomy. Of course, you have to control the metabolic products that she needs, calcium and other complaints, the gas, blood, maybe the problem maybe in these situations. But in these situations, I believe this ventricular fibrillation is near because the hemorrhage shock.
Thank you, Dr. Tele. Dr. Ontrak, your comment, sir.
Yes, in this case, I would try one external shock, and if that didn't reverse it, as Dr. Tele said, I would do an immediate intralateral thoracotomy. I assume the chest is already prepped, and then shock her internally, and then that has the advantage of allowing you to feel how full the heart is. And I agree. If the heart is not full, then I would clamp the aorta either at the hiatus or below the renals. If you have, it seems like you have good access. And but I would proceed to that right away. No more than one external shock, and then open the chest in this case.
Thank you, Dr. Untrack. Has everyone had an opportunity to comment at least once before we continue? Okay, back to you, Dr. Ferencz.
Thank you. So great comments on everything for our management. We felt that we had pretty decent control of the hemorrhage at this point between the Pringle maneuver and a clamp on the splenic hilum. So we actually did proceed with a left resuscitative thoracotomy with internal cardiac massage with ongoing MTP and management by our anesthesia colleagues. And we did achieve ROSC decently quickly. So she did not require cross-clamping of the aorta at that point. So we then proceeded with our hepatography. We did have a small left lung laceration from getting into the chest, a quick non-anatomic wedge resection, and we did temporary abdominal and thoracic closures. For our totals for our massive transfusion protocol, both in the resuscitation bay and in the operating room, we transfused 55 units of PAC cells, 55 units of FFP, 5 platelets, and 3 cryo, and had an estimated blood loss of about 20 liters. So from here, and I'll skip just because we have a little less time. From here, you know, our options for where should we go now that she is more stable. Operatively, we have hemorrhage control. To the trauma ICU, does she go to the pediatric ICU? Do we investigate the other injuries? This was all discussions we had. At this point, we were hemodynamically normal. She was warm, so we felt that given her poor GCS, and it did look like she had some external signs of head trauma, we really wanted to see what was going on in her head at this point. So we had the luxury of going from the OR immediately to the CAT scan, which isn't too far away. And then we found in the CAT scan an intraventricular hemorrhage, subarachnoid hemorrhage, subdural hemorrhage, occipital condyle fractures, a few rib fractures, and there was some active extravasation from her left chest wall, probably from our thoracotomy and in the left upper quadrant. She did have a left kidney laceration and some pelvic fractures. So from here, we made the decision to, instead of going, knowing that she had the active extravasation and the left upper quadrant was the most concerning, and the left chest wall, we actually went directly from CT back to the operating room. Here's some representative images from her scans. So we did have the nice luxury that we are able to get into our trauma operating rooms immediately. So we went straight back. We did find a clot in the lesser sac. There was a vessel off the pancreas that was bleeding, so we oversewed that to control it. Some intramuscular bleeding from the pec in the left chest, which we thought was from some coagulopathy and entering the chest. And we again did a temporary abdominal closure and closed the left chest. Immediately post-op, we consulted neurosurgery and orthopedics. She did have an EVD placed for the intraventricular hemorrhage, which was quite significant, as we saw, and had a lot of, over the next couple of days, a lot of issues with clotting of the EVDs and had multiple EVD replacements. At one point, bilateral EVDs in the ventricles, probably 5 or 6 drains replaced throughout the course. And then there was non-operative management of the pelvic fractures as well. 3 days later, she had stabilized and was doing quite well. So we planned our return to the operating room for abdominal washout, possible closure. And upon actually moving her from the ICU bed, which she was upright in the ICU bed because she had high ICPs with her EVD. So we moved her actually kind of sitting mostly upright from the ICU bed to the OR table with her upright as well. And just that little movement, she became very hypoxic. We were unable to ventilate, and with talking with our anesthesia colleagues, they were getting massive pulmonary clots out of her ET tube. So at this point, I'd like to open the floor for kind of what to do, and what were your thoughts if this were to happen?
Thank you, ma'am. Let's go to Dr. Untrack. Your comments, please.
So pulmonary clots, so not, in other words, in the airway, not pulmonary emboli. So in this case, if you can't ventilator, then I would, if you have it, I would put down a rigid bronchoscope to clear the airway, see where she's bleeding. You probably don't have that, so but you need to clear the clots. She needs to be suctioned aggressively, and then you need to determine where the bleeding is coming from. You may just be able to determine which side, and then, for example, if it's the left side, I would open up the old incision, clamp the hilum, and see if you can stabilize her. But if she's pouring blood into her airway, it's likely coming from a single source. You need to isolate it and then close it off by initially clamping whichever hilum will control it, and then proceed from there to do if it's the right side, thoracotomy on the right side, find the source of the bleeding and deal with it. But the first priority would be to clear the airway and allow her to ventilate.
Thank you, Dr. Untrat. Let's go to Ryder. Dr. Proctor, your comments, sir?
Do you know if she had a tag? It's my understanding that children who have head injury have a very high percentage of fibrinolysis shutdown, and that could account for the EVDs plugging up and also the large number of clots in the lung.
Her tags had been normal.
So did you do the LY30?
This was before we had it. If you remember on our last tag system, we actually weren't able to run LY30s.
Right, because this is the back end of the curve that basically there's no fibrinolysis.
Was that a question, Dr. Proctor, to Dr. Ferencz?
That was a statement.
Okay. Okay, Dr. Proctor, is that the extent of your comment, sir?
That is the extent.
All right, thank you very much. Let's go to Sao Paulo, Dr. Tele.
In these situations, we have a hypoxemic child, and you cannot ventilate in this moment. I believe that patients need, you can use ECMO for try to put in ECMO to adequate the hypoxemia for the patient, and then you can go to find where is the blending comes from the pulmonary, because they come from one side, but they come by a contusion. These patients have a very, very trauma machines, the high energy. So he have blood, have pulmonary contusion, may be very difficult to do. And sometimes the pulmonary contusions, when clots come through the airways, and the patient can have problem with this. So I think in this moment, patient needs to increase correct the hypoxemia. I think, believe in the situation, patients probably go to ECMO.
Thank you, sir. Go to Toronto, Dr. Ali.
Yeah, of course, if you have ECMO easily available, that's an option to consider. But first of all, if there are clots coming from the lung parenchyma, you have to determine. You try to determine where the site is. If it's an isolated site in the lung that's been injured, then you can control that area by identifying it and controlling the bleeding to that area, and even may have to do a resection to control the bleeding into the airway. But I think the first thing is to control the bleeding into the airway, and hopefully it is localized. If it's not localized and it's generalized, then you're dealing with a different situation where there's generalized hypocoagulable state causing bleeding. And in that situation where you can't ventilate the patient, then I would say ECMO would be a good choice to support ventilation and perfusion while the lung hemorrhage is controlled in due course.
Thank you very much, Dr. Ali. Let's go back to Ryder, Dr. Varon.
Well, if a bronchoscopy is not possible, either because it's not helping or the patient is so hypoxic that you can't even put the bronchoscope, I think ECMO is the only option.
Thank you, Dr. Varon. Dr. Kassim?
I think you are in a very difficult situation at this moment. You have to save the patient's life and stop the bleed. So two things. To save the patient's life, if you have the luxury of putting the patient on ECMO, go ahead and do that. And to stop the bleed, I think you'll have to take the patient to angio suite to see where she's bleeding from. So at least you can embolize that area. Thank you.
Thank you, Dr. Kassim. Does anyone have a comment before we return to Dr. Ferencz? Okay, back to you, Dr. Ferencz.
Thank you. So yes, we were thinking all the same things. Remembering that we did have CAT scans of her chest, which had some pulmonary contusions as expected, but no evidence of active bleeding within the chest 3 days prior. So this was a bit odd. So we actually proceeded with bronchoscopy to start with. Our anesthesia colleagues started. We're able to get out several old-looking clots, knowing that there were a lot more. Her SATs did come up, so she wasn't hypoxic for too long, maybe about 10 minutes. We performed a bronchoscopy still with clots. We actually called our pulmonary colleagues. They came in and additionally removed more clots. And then we wound up calling in pediatric ENT, who came in to do a rigid bronchoscope to get the remainder of the clots. Her SATs were much better, but we knew we really needed to get the clots all out and make sure there wasn't any active bleeding. So they came in and we actually performed a rigid bronchoscope with her pretty much at 30 to 45 degrees upright because of her ICPs. So they were standing on a lot of steps to do that. But they were able to clear the rest of the clots out of her airway. There wasn't any evidence of active bleeding. So the best that we could surmise that happened was when she was initially very coagulopathic, she did bleed into her airway. And when her coagulopathy corrected, it all clotted. And just the action of moving her from the ICU bed onto the OR table likely dislodged some of the clots. And that's why we had the compromise at that moment. But we were able to remove the old clots. There was no active bleeding. So we aborted the case for her abdomen at that point and took her back to the ICU. Overnight, she was doing okay SATs-wise in the 90s, but then about 6 to 12 hours after all the bronchoscopies, she started dropping again and became more hypoxic. So we've already kind of discussed at this point, we did consider ECMO for her. We performed another bronchoscopy. There weren't any clots in her lungs. So we did call our pediatric surgery team and we took her down to the OR for venous-venous ECMO cannulation. That was done by the pediatric surgery team. And then we also at that point reopened her abdomen. Everything was hemodynamically controlled. So we felt good about that. So we started heparinless ECMO, which is something we often do at our facility, especially with the head bleeds that she had. So our ECMO was managed by the trauma ICU team with pediatric surgery assistance, because there was kind of a discussion about, who's going to manage it, where's the best place for her, whether it's pediatric ICU, whether it's trauma ICU. Hadn't really had a 13-year-old with this severe of trauma before, in the recent past at least. So this was kind of what we came up with, was it's better for her to be in the trauma ICU with assistance by pediatric surgery. So the following day after ECMO, she did go into renal failure. So then we were discussing with how to deal with the renal failure on ECMO. And I'm just gonna skip ahead. So we went ahead and did CRRT in line with ECMO using pediatric oxygenators. One of our biggest issues with her ECMO was CO2 clearance, not necessarily oxygenation in the next following days. So the pediatric oxygenators actually helped us with a little more sweep as well. So this is just a kind of a diagram of how we had her set up with her venous outflow. And she had a single ECMO cannula in the neck with inflow and outflow. So we had our venous outflow, went to the pump, went through the CRRT device so she could be dialyzed. and then through the membrane oxygenator for the ECMO and returned in her neck. Oh, sorry. Is there a comment?
Were you want us to go around right now?
Oh, we can.
Okay, whenever you're ready. So let's go to Dr. Kasim.
Amazing case. And so far you're doing well. I don't have very much to add to this.
All right, thank you, Dr. Kasim. Let's go to Toronto, Dr. Ali.
Well, I don't have anything. I'm interested in, watching this patient and see what, if she would give us an indication that there would be some other type of intervention. At the moment, we are controlling her hemodynamics, we are controlling her renal failure and her oxygenation. I think we just have to wait and see what happens and how she behaves to determine what other step we might need to consider.
Thank you, Dr. Ali. Let's go to Dr. Untrak, please.
Well, so far you're doing great. So, she's all the fires have been put out, and don't stay too far from the ICU. Just wait to see what happens next. But I think you're doing great. I'm impressed.
Thank you, Dr. Untrak. Let's go to Ryder, Dr. Barron.
And no additional comments.
Thank you, sir. Sao Paulo, Dr. Calais.
It's a great case, and no comments more.
Thank you, sir. Let's go back to Ryder, Dr. Yee.
I think I had to step out for a few minutes. I came back as she was discussing the OR where we had to basically we discussed preemptively cannulating her. She did not meet the strict criteria, but I was really worried about the ICPs. And in fact, they cannulated her in reverse Trendelenburg because she really couldn't tolerate, laying flat all that much. So I was worried that if we waited for her to meet strict criteria for ECMO, that her ICPs would have gotten so bad at the time that it would have been impossible to move her from the ICU. So we preemptively did it. I'm glad we did. This sort of inline sequential ECMO CRRT is kind of a new thing for me. I was also actively managing her TPN at the time, and it was quite challenging to figure out how much to prescribe her and how to, what her needs were, because, for a 13-year-old and then with the TBI, with ECMO and with CRRT, it was challenging. But that was just one additional thing that was kind of throwing us all for giving us a run for our money. But I want to let Sarah actually finish the case, and then at the very end, I'll give you my my follow-up with the patient.
Thank you, sir. Any comments before we return to Dr. Ferencz? Okay, back to you, Dr. Ferencz.
Great, thank you. So through her course, immediately, after she had ECMO and CRRT, she actually did very well, and she was decannulated from the ECMO on post-trauma day 11. So she required just about 7 days of ECMO.
Actually, so we could have actually removed it, I think, a little bit sooner. Her oxygenation and her ventilation had improved, but it was the pediatric oxygenator, right? I think you were going to mention that in the next slide. So go ahead. Sorry, I didn't.
Yes, absolutely. Her hypoxia was no longer an issue, and she was really on the ECMO for that 7 days, almost all of it for the CO2 clearance. So we finally got her sweep down to a level where we could decannulate her from the ECMO. We continued her on CRRT and actually kept her on the pediatric oxygenator for just the sweep. You can do about 5 liters of sweep for CO2 removal on that. So she wasn't requiring the oxygenator for oxygenation per se, because she didn't have any hypoxia anymore. So it was really clearing the CO2, which was kind of interesting. She did wind up getting a trach at about post-trauma day 41, and then she did get a GGA2 placed later on. In just about 2 months after her initial trauma, she was stable enough from a trauma standpoint that she was transferred to pediatric rehabilitation. So that was excellent for us. All her EVDs were out. She had a mental status. She was talking to us, and it was a relief and a pleasure I think, for everyone involved with that. And just not to steal Dr. Ye's thunder, but she was discharged from pediatric rehab just about 3 months after her initial trauma. She was discharged home with her family. 3 months post-op, she was seen in the trauma clinic. She was able to tolerate a diet and her GJ was removed. About 6.5 months, she was seen for her last neurosurgery clinic appointment, and she had an excellent recovery. She actually came into the trauma center and would walk around and say hi to everybody, which is just a heartfelt thing that we all needed, and it was great. Because of the COVID pandemic, she was doing homeschooling. So she actually caught up on all the schoolwork she missed for the 3 months she was in the hospital and doesn't have to repeat a year. So just a fantastic outcome. As a fellow, this was my first half of my critical care year taking care of her. So I really felt like I just dove into the deep end, taking care of her, but I really learned a lot from her. And I think all of the services that we had at the facility and everything that everyone did was fantastic. And it was a wonderful experience for me to learn. So I'll go ahead and let Dr. Ye, I know he had some more comments on it.
Yeah, well, just about a month ago, I was walking through the lobby and I saw a familiar face. she had so she was actually accompanying her father, who was here for some like urology clinic appointment, and I almost didn't recognize her. Actually, I recognized her father because I spent more time, you know, talking with him and stuff. But she looked like a typical Miami teenager with like a tube top, neon pink tube top, and like a fishnet halter top over that, and like you know, tiny little shorts. And I was like, oh my gosh, she's back to a normal teenage girl now. So it was really great to see her, you know, basically return to a normal life. So yeah.
Thank you, Dr. Ferencz. Were you ready for final comments, ma'am?
Yes, I had actually just listed everything because I had presented this for our facility, just, congratulating all the teams. So these were all the teams that were involved, and we just really had a wonderful outcome. So yep, that's all from me.
All right, thank you, ma'am.
I don't see anesthesia there.
You're right, Dr. Varen. Anesthesia had a huge impact.
With that said, Dr. Varen, your final comment, sir.
Well, this is the typical case that we all will remember, and this is why sometimes we work in for every other patient trying to look for this type of outcome. So it's great. This is what inspires us to be very aggressive in the other patients. Thanks for presenting this case.
Thank you, Dr. Varen. Dr. Clay, your final comments, please.
It's a very great case. It's very difficult to treat these patients in these situations. You have all the means of the equipments to treat these patients. It's very difficult to treating anywhere these patients. Congratulations for the presentation, and thank you to share us with the case.
Thank you, Dr. Calais. Dr. Ferencz, just got a private text here about recognition for the nurses of TICU.
Yes, absolutely. All the nurses did a great job.
And housekeeping.
Yeah, and housekeeping too. We had a lot of nurses that would request to take care of her because they were just so involved and wanted to help. So yeah, they did a fantastic job.
Yes, ma'am. Let's go to Toronto. Dr. Holly, your final comments?
Well, I just have to, it's so gratifying to have a case like this, isn't it? And it makes it worthwhile, all the efforts we extend in terms of trying to salvage our patients, especially in a young patient. Not that age is the big criteria, but I am sure that there were many times during the course of this young patient that you thought you would have lost her. It was good that you kept the spirit up and you continued to persist, and everything that came up, you tried to sort them out and deal with them in turn and go to the next stage, and eventually you had a good outcome. And it's a good lesson for all of us. Just hang in there and do what you can based on what you can identify and treat, and it can be very rewarding. And I want to congratulate you all for doing an excellent job in salvaging this patient who was in severe, with severe problems that she may have succumbed to had it not been for your heroic measures. Congratulations.
Thank you, Dr. Holly. Dr. Untract, your final comment, sir.
Yeah, a superb case. Gee, if I ever decide to start riding a motorcycle, first I'll move to Miami, so I'll be, in the right place, in the right neighborhood. But is this girl now wearing her seatbelt? Really, it just, there should be some sanction for parents that don't have their kids wear seatbelts. It's really, really too bad. Most of this probably could have been avoided. And
yeah, and actually she was in the back seat and her mom was the driver, and her parents were beside themselves at this accident, and I think they've become advocates, for that as well.
Right. I think it's probably the law that you have to have your kids in seatbelts. But and then also one final thing: what do you think precipitated the ventricular fibrillation? It wasn't hypotension, so it was something else.
Probably some electrolyte disturbances, as Dr. Varen had said, and obviously anesthesia did a great job because the chest was open. She got a little bit of cardiac massage, and we obtained ROSC. So I think it was just catching up.
Yeah, hyperkalemia.
So without a shock, then, is that right?
That's correct. She did not require any shock.
Yeah, there was a slight delay in getting the internal paddles set up. So we, when she went into fib, I waited for, I thought about it for about 3 seconds, and then I just went in. I didn't want to waste time because I was worried about her TBI. So I didn't want to waste time for medical management. So I just went ahead and went in and was doing open cardiac massage, waiting for them to plug in and set up the paddles. And by the time they had them ready, and I took my hands off and I looked, she was actually back in a perfusing rhythm. And then she had a strong pulse in the aorta at that point, and I didn't really feel like we needed to cross count the aorta. So I don't know if it was necessary or not, but I do believe that open cardiac massage is superior when it comes to coronary perfusion pressure and also cerebral perfusion pressure. So if I'm there, if I have the knife in my hand anyway, I didn't hesitate. I just went in for it.
Plus the hand of God. Plus the hand of God.
Right. No, I mean, I agree with that, but there was no medical management. There was no insulin and glucose or nothing to change any of the metabolic parameters. It just was, it's a little puzzling, but, obviously you did exactly the right thing.
Actually, when we see that happen, we usually I have to look at the anesthesia record. I didn't do this case. We usually push calcium, assuming it's hyperkalemia.
Dr. Kassim, your final comment, sir?
Well, isn't it nice to save a life with all the killings that's going on? So, doctor, you will remember this case for the rest of your life. You're so young, you've got so many years to go, and this will come back and give you good feeling of the good feeling that you will have. A fabulous case, and you did a fabulous job in saving this patient's life, your whole team. I congratulate you.
Thank you, Dr. Kassim. I see that Dr. Marttos is with us. Do we have any other comments from the participants before I turn it over to Dr. Marttos for final comments? Okay, Dr. Marttos? Okay, Dr. Marttos. Okay, everyone, thank you very much for joining us. And please watch your email for announcements for our next session. Let's see, let me make sure that's not him trying to talk to me. No, that's not him. He's probably busy. So, as I said, thank you very much for joining us. Watch your email for our next session. Please be safe. Take good care of yourself.